Welcome, everyone. We're going to go ahead and get started. I can't see a thing, as everyone else has said who has stood up here, and it also is very echoey, so I'm just going to carry on. Welcome to the Rehabilitation Connect Forum. I am so glad that you all have joined us this afternoon. My name is Amy Byreth, and I am thrilled to be with you today, to learn with you. Just a bit of history. The idea for the Rehabilitation Connect Forum actually was the brainchild of Amy McConkey Robbins, who just kind of scooted across the stage and scooted back that way. And so over the last couple of years, we have taken her idea and tried to structure it and develop it and grow it. And as a result of feedback of you guys, we made some changes this year. And so all of our presenters actually were selected from the pool of abstracts that were received by individuals submitting to the conference. And so we have some fantastic presentations today. Each of the pediatric speakers will have 15 minutes to talk, and then we will have time for hopefully some robust Q&A at the end. So I'm not going to take any more time, especially since I was chatting and got us started 2 minutes late. I would like to introduce Dr. Teresa Caraway, who is going to come up and then introduce the pediatric portion of the session and our speakers for today.
Well, we all walked in the room and we looked at each other and we said, yes, you are my people, because we're so excited to be able to talk about outcomes and how we can improve outcomes for children with cochlear implants. So we have fantastic presentations that are pending that we get to participate in. And as we listen, please think about questions you might have, continued dialogue and conversations you'd like to have together, and let's digest and discuss after these speakers finish. Our first speaker will be Dr. William Cronenberger, and many of you know Cronenberger. I told Bill that this is a red letter day when you get to hear Andre Crowell and Bill Cronenberger on the same day. But he is the professor of child psychiatry and director of the Division of Psychology at the Department of Psychiatry at Indiana University School of Medicine. And he serves as the chief of the Pediatric Psychological Testing Clinic and psychologist in the Deaf and Hard of Hearing Clinic at Riley Hospital for Children. He's received numerous awards for teaching. He's been the past NAPARCO lecturer that he's presented here at ACIA. But his research really addresses the influences on the development of executive functioning, memory and learning, particularly in children with hearing loss and cochlear implants. His clinical work involves assessment and treatment of ADHD learning, executive functioning, and disruptive behavior disorders. An author over 100 journal articles and book chapters, as well as several tests that are used both nationally and internationally. He's been a principal investigator and co-investigator of NIH-supported funding, looking at the development in children with hearing loss and cochlear implants. And he will be speaking on understanding the variability and long-term outcomes of prelinguically deafened children and adults implanted children. The second one we have is Dr. Castellanos, and she is an assistant professor and the Philip F. Horton Scholar in the Department of Otorhinolaryngology, Head, Neck, and Surgery at Indiana University School of Medicine. She received her PhD in developmental science from Florida International University, where she was trained in multisensory perception. She then completed a postdoctoral fellowship at Indiana University School of Medicine, where she focused on how neurocognitive systems are impacted by a period of early audition deprivation in children who use cochlear implants. Her research really seeks to understand the dynamic interplay between the brain, body, and environment across the lifespan in pediatric and older adults with cochlear implants. And then our third speaker will be Dr. Cameron Carden, and she's a certified speech-language pathologist, a listening and spoken language specialist, certified auditory verbal educator, and has over 15 years experience working with children who are deaf or hard of hearing using listening and spoken language. As a practitioner, she taught in oral preschool programs, served children and their families through early intervention, and provided outreach services to students and their teachers in public schools throughout the state of Alabama. Dr. Carden currently serves as a research associate in the Department of Psychology at the University of Alabama. Additionally, she is an adjunct professor at the University of Alabama in the Department of Special Education and Multiple Disabilities and Samford University in the Department of Communication Sciences and Disorders. Long list of where she serves and volunteers, and her research includes complex language development and ecologically valid language assessment practices for preschoolers who are deaf or hard of hearing using listening and spoken language. And then our fourth presenter is Dr. Evan Patel, and he earned his medical degree from Northwestern University Feinberg School of Medicine and is currently an otolaryngology resident at the University of California in San Francisco. He has a strong passion for otologic research and surgery and improving hearing outcomes with implantable devices, and he's planning to pursue a fellowship in otology and neuro-otology. This is the valuable thing that we've been playing around with, the remote. And then our fifth speaker there is Dr. Anna Marie Sola, and she is a fourth-year otolaryngology head and neck surgery resident at the University of California, San Francisco. And she's passionate about hearing-related health and speech and language outcomes in children. And her project is studying trends in automated speech outputs and language development in children after cochlear implants, with the hopes of identifying clinically meaningful predictors. So we are in for a great afternoon. Get your thinking caps on, and I look forward to the discussion after we hear these fabulous speakers. Dr. Cronenberg.
Hi, everybody. Thanks to Teresa and Amy and the conference organizers for this opportunity to present our research on young adult outcomes of pediatric cochlear implant recipients. So these are my disclosures. None are relevant to the topic of the presentation today. Before I get started, I do want to thank all of our lab members, our colleagues, partner organizations, stakeholders, and NIDCD for their support for our research. And so let's get started with something that's important to all of us, which is the clinical question here that I'm going to attempt to provide some information about in this presentation. And so our developmental goals for pediatric cochlear implantation. Boy, you're right, Teresa. This is like a flight deck of a 747. Let's hope I don't. Okay. Our developmental goals for pediatric cochlear implantation extend beyond childhood. And the question I want to address today is, what happens to pediatric cochlear implant recipients in adulthood? Or if you're a surgeon or an audiologist or a pediatric psychologist talking to a parent who's trying to make that important decision, they wonder, how will getting cochlear implants promote my child's growth, not just into a better, hulking, surly teenager or school-age student, but a well-adjusted, socially connected adult? And so I'd like to try to shed some light on that today. We all stand on the shoulders of giants, and this is true for this presentation as well. There's been some very good research that's been done previously, and you can see the bullet points. I won't reread them for you, but to summarize, the majority of young adults with, who are pediatric cochlear implant recipients do quite well, and the results have been favorable. There are mild to moderate delays in some areas relative to matched samples of normal hearing young adult peers, so there is still some work to be done, but overall the results have been pretty favorable. Now, that said, no research is perfect, and the prior research has some limitations. The first 4 bullet points you see here essentially can be summarized as, the samples that have been studied are heterogeneous. A lot of these articles will say that they are studies of young adults, pediatric CI recipients. Some include 13-year-olds. Your 13-year-old may say they're a young adult. They're probably not. Other studies may include people implanted at age 12, 15 years old. Obviously, that's not early implantation. In fairness, it's hard to get a sample of young adults with implants, particularly given that we only started implanting children in the late 80s and only got FDA approved in the early 90s. So those studies were dealing with what they had, but there's a need to look at more recent cohorts. And so I want to talk about what I mean when I say cohort, because that's going to be an important thing in the rest of this presentation. When I say a cohort, what I mean is the year that you were implanted, because the year that you were implanted has a lot to say about the technology and interventions that you had. And to put it into simple terms, someone implanted in 1992 had a very different engineering and device and speech-language experience and educational experience than somebody implanted in 2002. So there's a need to look at cohorts. And most of the studies that we have are focused on the earlier cohorts because that's how time works. It takes a while for a child to grow into an adult. This is not a limitation per se, but a consideration is that most of the prior studies have been between group studies. And so this is an important way to think about research. If you look at a lot of the prior studies, and this is an important research question, the question has primarily been, how does the sample of young adults with implants compare to the sample of normal hearing young adults? And so what's being compared are 2 mean scores. But those mean scores are just the middle of a big distribution of each of them. And when you look at the actual distribution, there's more variability in the cochlear implant distribution alone than there is between young adults with CIs and normal hearing. So when I say within groups, what I mean is what explains the variability within the group of cochlear implant users? Or why not look at the young adults who are doing really well, find out what their secret is, and let everybody do that, right? So let's try to explain outcomes by looking within groups. So the study I'm going to present is a within group study. We don't have, well, we have a normal hearing sample, but you got to go to poster 151 to see that. That's a little plug for that. This is a within group study. And since they gave me 15 minutes, I said, let's study everything. So we'll look at speech recognition, we'll look at language, we'll look at psychosocial, we'll look at neurocognitive. We all know in ACIA time, 15 minutes is like forever. Okay. They just sped up the clock on me. That's not fair. Okay. So what's our research goal? We're looking at a within group study. We want to pay attention to cohort. And ultimately what we want to do is improve our understanding of the factors that determine psychosocial and speech and language outcomes in young adulthood after pediatric cochlear implants so that we can help parents, surgeons, audiologists, whatever, with the expectations and the interventions to promote optimal development in young adulthood. Just some terminology in that second bullet point. When I say prelingually deaf, under 3 years of age, most of our sample is congenitally deaf at birth. Early implanted, we just defined as 6 years and under. That's kind of arbitrary. Later, we've gone to 3 years and under. And by young adults, we mean 18 to 29 years of age. And our sample was implanted between 1998 and 2003. You'll see in a second. So here are our participants. We have 3 cohorts. The cohorts are named based on the median year of implantation. So cohort 1991 is 6 young adults. They're 23 to 29 years old, and their median year of implantation was 1991, give or take a few years. Cohort 1995, median year of implantation 1995, 12 of them. They were 18 to 22 years old, a little bit younger because when we ran that study, of course, we didn't have as many old people. That's the way that time runs. And then cohort 2001 is our most recent group, and these are 3 different studies. They 18 to 22 years old and implanted in 2001. So when you hear cohort 1991, 95, 2001, think about the year that they were implanted. And again, implants, a lot different in 91 than in 2001. Okay. Again, we're looking at a variety of outcomes. Here are our measures, just to run through them quickly. So speech recognition and language, we had a speech recognition measure, LNT, you may be familiar with that, vocabulary, Peabody Picture Vocabulary Test. I want to take a second to talk about functional language. Functional language, basically what we did was we asked the young adults, you tell us, how good is your language in everyday life? How well do you understand things? How well do you remember things? In other words, what's your real world language experience? Not what we get in the lab. Our psychosocial outcomes, you can see psychological symptoms. This is, I'm going to use this interchangeably. Think of this as like emotional problems, just general emotional problems with adults. These are all self-reported, so that's important. We're hoping at some point to do a study with proxy or parent report, significant other report, but right now self-reported. Social personal adjustment is interpersonal adjustment, and then executive functioning behavior problems is attention and concentration. So 3 areas of psychosocial and behavioral outcomes. And then neurocognitive outcomes, our beloved digit span test to look at verbal short-term and working memory, and then we also measured nonverbal IQ. So we looked at a variety of areas, break down our research questions into 2 areas. Aim 1 is what predicts speech and language outcomes, and aim 2 is what predicts psychosocial outcomes. So place to start with speech and language outcomes is, do the cohorts differ in their speech and language outcomes? This slide shows the results of ANOVAs, looking at our 3 speech and language measures, speech recognition, vocabulary, and functional language. The different highlighting is significantly different. So if you see different colored highlighting, that means P less than 0.05, they differed significantly. If it's the same, they didn't. And the take-home message here is for speech recognition, the cohort with the old cochlear implants showed poor speech recognition, as we would expect. The 2 newer cohorts, better speech recognition. Vocabulary, there was no difference on the ANOVA stats. What can you say? If you go down to the poster, I ran more complicated stats on a between-group study. They're actually, the 1991 group is a little lower on vocabulary, but it didn't come out in these stats. And then functional language, this was paradoxical. Our newer group, the group implanted in 2001, said they had more functional language problems. We think this is because they're more aware. They have higher aspirations. Teddy McCracken talked a little bit about how aspirations interact with people's feelings about outcomes in a really good presentation yesterday. So the other thing to know is that mean score 0.95, that's really not very high. You have to get a 2 or higher to be in a clinical range. So they're not reporting big functional problems. Second area we looked at with speech and language outcomes was all device and hearing history. And in the interest of time, I can't go through every one, but let me just summarize by saying the 2 in green, so residual hearing before implantation, and communication mode, which is the Ann-Gear scale, where higher scores mean more oral or listening and spoken language, lower scores mean total or simultaneous communication. I should point out, everything you see from now on, we statistically controlled for cohort because we found cohort makes a difference. So we've accounted for cohort in all the analyses you're going to see. These are just the actual correlations, and basically higher pre-implant PTA is poorer speech recognition and vocabulary. Again, poorer residual hearing. And then more listening and spoken language, oral communication, better speech and language outcomes in adults. So when you think about it, that's lasting a long time to come through to adulthood. Now, what about psychosocial outcomes? You can see psychological symptoms, that's emotional problems, social and personal adjustment, think of that as like interpersonally getting along, and then attention and concentration. And we went in saying, look, speech, that's got to be a big deal. Speech vocabulary, sure. Functional language, maybe, we're trying that out. And then our beloved neurocognitive, right? Got to be speech and language. This is why you do research. Epic fail on the speech and language. Vocabulary, unrelated to emotional symptoms. Speech recognition, unrelated to emotional symptoms. My beloved working memory, unrelated to emotional symptoms. Nonverbal, and then functional language has a gigantic relationship. Adults who say day to day, I use language well in the real world, have fewer emotional problems. What about interpersonal adjustment? Same thing. It's functional language, not vocabulary, not speech recognition, not memory, not nonverbal IQ. All right, what about executive functioning problems? Oh, surprise, functional language. Again, in all cases, better functional language, better outcome. Nonverbal IQ sneaks in there, so it helps to be smart. You can, I don't know, it helps you focus better is what they're reporting. But then we had a question. All right, look, if it's PPVT, I've done PPVT for a long time. Digit span, I'm good with that. Functional language? what is functional language? Well, remember what I told you at the beginning. It's language in real world, learning, communication, work, home, and other settings. It's understanding, remembering. It's what you have to do in the real world. So then the question becomes, all right, well, what predicts functional language? And I thought, here's where vocabulary and speech recognition are going to come out, right? They are going to relate to functional language. They've got to because it's language. No. Great. So now I'm wondering, well, what is my functional language measuring, right? Turns out that verbal short-term and working memory and nonverbal IQ are related. So there's something about general cognitive functioning. So now I have a phone call with my colleague David Pisoni, and I say, I'm not getting anything on vocabulary. I'm not getting anything on speech recognition. He says, do you have the self? I said, just a few of them. He says, run the analysis. All right. Guess what? Functional language is related to following directions, recalling sentences, and formulating sentences on the self. What are those measures? Those are the higher order language measures. In other words, it's not the words, it's not the basic speech recognition, it's being able to use it in a higher order way to understand and effectively communicate with others. So, and full disclosure, and I put the ends here, this is a subsample. The reason I didn't include the self at first is these studies were done a while back, we didn't include that in the studies. So, where do we start? This is my wonderful hypothesis, right? I've been doing this a long time. I'm confident, right? Wrong. Here's where we finished. Functional language is the thing that predicts psychosocial outcomes. None of the others directly predicted psychosocial outcomes. But verbal short-term and working memory and nonverbal IQ and higher order language do predict functional language. 15 minutes, I got a minute and a half, which means I got to get you a take-home message so that this sticks. All right, I am a working memory guy after all. Okay. What's the take-home? Cohort and early experience matters. We have to begin talking cohort when we do young adult studies, okay? And the second bullet just summarizes what I said before. Second, functional language is central for young adult psychosocial adjustment, but we don't really measure it all that much. And part of the reason we don't measure it is if I asked you, what's your functional language measure? You can't use a Vineland. Vineland is great, but that's kind of an adaptive behavior delay. That's pretty basic. These are adults, all right? My summary quote is, it's not how many words you know, it's what you do with the words you know. So, what does this mean clinically? It means as we look down the line, as you work with that toddler, that preschooler with cochlear implants, think about long-term young adult outcomes being related to functional language, building functional language in, along with all the other work. We're obviously doing something right. Our cohorts are getting better. And think about we need to do better research. And that third bullet point is, I know what has to be in a lot of people's heads, which is you just told us measure functional language. Where's your functional language measure? We're working on it. We're also working on better research to understand this. Thank you all for your attention. I know it goes fast. Here's the contact information if you have questions, and you can get the slides at the website. Thanks a lot.
I just want to let my media friends know that I have some videos with sound. Okay, so. Wait, oh,
This is forward.
Oh, okay. Thank you. So today we'll talk about stress appraisal and coping responses in pediatric CI users. These are my financial disclosures, so we've been happy to have funding from the NIDCD and the NCATS. I also want to disclose that as a true humanitarian, I sacrificed myself this week for a squirrel. So I self-sacrificed both my body, probably my prefrontal cortex, and definitely the bike that I rented in order to not murder a squirrel. And this will be very relevant because that squirrel made me resilient. And so we'll talk about resilience. So my research program focuses on the whole child. So how does hearing loss affect the whole child as they developmentally progress from childhood into adolescence, young adulthood, older adulthood. So today I'll quickly review what I mean by neurocognition, and then I'll talk about functional outcomes in pediatric CI users. So what do I mean by functional outcomes? I mean social, emotional, behavioral. And so I think Bill did a great job at sort of summarizing that. So as we all know, with the advent of pediatric cochlear implants, the majority of the research focused on speech and language outcomes naturally. However, in the last couple, decade, research has shown that hearing loss cascades into the prefrontal cortex and may press down into functional outcomes, so more distal effects. So what I mean about the prefrontal cortex, I mean language and executive functioning, right? So the prefrontal cortex is considered the conductor of the neurological orchestra because it works with the other processes, the other frontal lobes, to store and process information. So although executive functioning is an umbrella term, there is some consensus that there are 3 core executive functions, which are working memory, inhibition concentration, and attention shifting. So working memory, you process and store representation in order to achieve a goal. Inhibition concentration is the ability to exert control over a dominant or automatic response. And attention shifting is being able to shift mental states, responses, and tasks. So executive functioning can be both cool and hot. So a cool executive function is what we all have studied in pediatric CI users, which is how do they control their cognition in order to achieve a goal? Well, in psychology, there's also a hot executive functioning. How do you control cognition and your affect in an affect-provoking task? So how do you do these 2 things simultaneously? So self-regulation, it's an everyday process. And although I told you about 3 core cognitive processes in a very distinct manner, they don't occur in a distinct manner. In a natural environment, they're co-occurring. And so it's this cyclical pattern where you identify a goal, you plan, you execute, and you evaluate. And that keeps updating as more new information is received. And on the right here, here you can just see although kids are using core cool hot EF, they're also thinking about how the hot EF things like social, emotional, behavioral functioning in a cultural environment. So be patient, focus, take turns, be resilient. So executive functioning in the real world is quite difficult. So all the data that we've shown before in the last 15 years about cool executive functioning, that's the best these kids can perform in a very controlled environment. So what does this look like when they're given tasks that are maybe a little more stressful, a little more challenging, a little more like the real world? So flexibility in thinking allows us to have self-awareness, awareness of others, engage in novel problem solving, capacity to self-regulate and soothe, capacity to cope with disappointment. So when you think about a mentally stable individual, is somebody who has flexibility in their psyche. They can flexibly shift mental states and goals in a very effective manner. And some might say that being flexible in your thinking is your ability to weather the storm of life or the squirrel. So I've talked about neurocognition. Now we'll talk about social functional outcomes. So right before COVID, there was a study done by Nationwide Children's Hospital in Ohio showing that 1 in 5 kids struggle in such a way that they are significantly impaired in a mental disorder. So we thought, well, normal, typically developing kids, 1 in 5, that's a huge number. How does it present in pediatric CI users who we know already struggle with language and executive functioning? So when we look at social, emotional, behavioral functioning, the DSM categorizes it into 2 broad categories. So externalizing behavioral problems, it's basically antisocial features that are not age appropriate given the social cultural situation. So aggression, overactivity, disruptiveness, defiance. And internalizing behavioral problems are behavioral problems inward to the child's mental psyche, so depression, anxiety, somatic complaints. So this project was conducted in Indianapolis School of Medicine, and we had a sample of 110 child and adolescent participants. There was 57 CI participants that were matched to 53 normal hearing, atypical, nonverbal matches, and they ranged from 7 to 19. We gave the parents the BAS, which is a multidimensional questionnaire that assesses both internalizing and externalizing behavioral problems on a 4-point severity scale. So it's a clinical scale, meaning that the higher the score, the more problems the parents report. So the BAS has 7 behavioral symptoms and also has an adaptive scale. So this is interesting about the BAS. So in the behavioral symptoms, the higher the score, more severity. But in the adaptive skills, you want kids to be more adaptive, so higher the score, the better. So you're looking for low scores and then higher scores. We also developed a questionnaire called the CHAOS. It's also a proxy parent report questionnaire, 22 items, clinical severity scale, higher the score, worse problems. And so here are the data. So if you can tell, parents reported that their CI adolescents were significantly different than their normal hearing peers on literally every single subscale of the BAS, except for anxiety, where they're presented the same. So parents of CI users are saying, hey, would they have more hyperactivity, more aggression, more depression, more attention problems, atypicality, withdrawal? We look at adaptive skills. We want them higher, but if you follow the gray scale, they're actually lower, and they're significantly lower on all subscales of the adaptability. So they're expressing more issues with social skills, leadership, activities of daily living. We look at the CHAOS. And the CHAOS shows exactly the same pattern. They're significantly different on everything except for cognitive problems. Then we looked at, well, there's a lot of individual variability. What if this is just a couple kids that are throwing the data off? So we look at the number of elevated scores. So how many of these kids present in the at-risk to clinically significant range for a diagnosis? And so in gray, the dark gray is the CI users, and about 60% of CI users do not show clinically significant difficulties. So that's great. But as you can see, when they do present with an issue, they have more than one issue. The CHAOS has a similar pattern. 40% of the kids with CIs do not have clinically significant issues, but when they do, it's more than one symptom. So it seems to be a constellation of problems if they have problems. So we thought, okay, well, what's the role of neurocognition? Does neurocognition play a protective role? In fact, it does. If you have better language and better working memory in CI users, you have better functional outcomes, so fewer behavioral problems, fewer attention problems. And in normal hearing peers, again, if you have better attention shifting and concentration, you have better functional outcomes. So language and executive functioning seems to serve as a protective factor, both CI and normal hearing. Okay, so we said, well, the data is interesting because we can show differential differences between normal hearing and CI, but there's 50% of the kids with CIs that we can't predict whether or not they're going to be at risk. So how do we account for this intra-individual differences? How can we predict whether a CI user is going to be completely fine or fall within the at-risk to clinically significant range for a diagnosis? So we thought, okay, let's run this beautiful model where we look at cool executive functioning, which we've all done, and we'll call that the cognitive risk pathway. And let's look at hot executive functioning. Maybe that's what will predict the difference between CI users. Maybe it's how they function in situations where there is affect. So they have to control their affect and control their cognition. Maybe that's the key. And we're going to call that emotional risk pathway. So this study was conducted at Ohio State in partnership with Nationwide Children's Hospital. We had a pilot sample of 16 kiddos, 8 CI users, 8 normal hearing peers. There were preschoolers, little darlings aged 3 to 6, and their inclusionary criteria was that they were implanted by age 24 months. In reality, most of the kids were implanted by 9 months, which is great. English was the primary language of home, goal of spoken oral language, no syndromic diagnosis of hearing loss, and no significant developmental, neurological, or cognitive delays like epilepsy. So we did what we know we do well. So we did a neurocognitive battery where we tested their neurocognition, their language, and cool EF. And then we adapted this laboratory tab, so like laboratory temperament assessment battery that has been developed in normal hearing, not even preschoolers or like toddlers. Like we're gonna develop this, we're gonna adapt it, and we're gonna use it in an older sample, right? Because like CI users usually show a delay. Let's make it so that it's appropriate for them. And this was our measure of hot executive functioning. So we presented these low levels of predictability and controllability that were small challenges where the child had to both control their emotion in order to complete a cognitive task. So like emotion plus cognition equals hot EF. So it was a 20-minute battery. It started with a simple parent separation, which we didn't intend to be a hot EF task. We just needed the parent to leave in order to get the child to play with these really interesting toys that we've been talking about for the last half hour. So the task was like, hey, the parent's gonna leave, and we're gonna measure their distractibility about these toys and whether or not they touch these toys. And this is gonna be our measure of like controlling their emotion in order to finish the cognitive task that is on the table. So cognition, cool EF, focus on the things on the table, control your excitement about these really cool toys that we've been talking about that you may win, but you can't touch. So this is Alana. She's 6 years old, bilateral CI user. She is bilingual. She's a beautiful English speaker and a Mandarin speaker. These are clinical notes on the right. So the clinician said, beautiful speech, very soft-spoken. Would rather say, I don't know, instead of providing an incorrect answer. That's interesting. I'm gonna play you her video. This is just trying to get the parent out of the room so we can do the first task.
Real quick, okay? I'll be back in 2 minutes.
No.
Hey, what's wrong? I'll be back. I'm going to the restroom real quick. I'll be back in 2 minutes.
I'm scared. No. Oh, 不要.
I'll be back in 2 minutes, okay?
No.
Hey, I'm going to the restroom.
Can you pause the video?
I will see if I can pick up some gifts for you, okay?
Oops. So I won't play the entire 22-minute session, but as you can tell, we couldn't even get the parent out of the room because Alana was upset. The clinician said, argued with dad in English, and then she switched to Mandarin, cried the entire time while dad was away, curled up in chair, didn't get up, was no longer interested in these really interesting toys that she had expressed interest in, and she continued to code switch with dad, which shows us that she has really good executive functioning. And in fact, not only the clinician notes, but the actual behavioral experimental numbers revealed that Alana has an amazing nonverbal IQ and above normal language in English. And we actually took her transcriptions, or took her Mandarin had somebody transcribe it, 3 different independent reviewers, and they coded her intelligibility, and they said, her Mandarin is near native. Couldn't tell that she was a CI user. So she's a fantastic CI user. But the moment we tried to remove parent, which is a normal stressor, right? Like, you drop off your kid, that's a normal thing. It destroyed her. She literally curled up onto herself. This is an example of Joey, the same. Last task. We did the actual task, which is a toy frustration box. We give them a blank toy, and we say, like, hey, mom picked out this toy. We're going to put it in this box. We're going to teach you how to use this lock. They're super excited. We give them the keys. We walk out. Unbeknownst to them, none of the keys work. So now we're measuring, like, hot executive function. Control your emotion while you're trying to solve this problem. This is a video of Declan. Ironically, I am also wearing a ACIA lanyard in that video. The video is going to take a couple minutes, but basically we saw the same thing we saw with Alana. He was completely beside himself, and he was so distraught that he actually went underneath the table. Didn't want to interact with anybody. So we thought, man, we were wanting to test hot executive functioning. And in reality, the normal hearing kids got us the hot executive functioning tasks. Like, we saw that beautiful data with them. But we were really stressing these CI users. They didn't even have the opportunity to exert hot executive functioning because they were stressed. So we needed to have some flexibility in our thinking. So we thought, what if we're actually tapping into stress? So this is Lazarus' model about stress. And a task is appraised as stressful when the resources the individual has does not match the event that is happening. So if the child doesn't have good language or cannot deploy good language and executive functioning in an effective, adaptive manner, that event is appraised as stressful. We looked at the same data, but now we looked at it with the lens of stress. We truncated the videos into 15 seconds, and we looked at emotional reactivity to the stressor and sustained stress activation. This is the normal hearing in CI users. CI is in lighter color. Kids with CIs were faster in getting upset. When we looked at their intensity, they were expressing more angry feelings. We looked at their duration, so how long were you upset? And they were significantly more upset. And then we looked at how many times they tried any kind of coping strategy, and was that different? And of course that was different. So in every single aspect of stress, they were significantly poorer. I'll skip over this. So what we're doing now is like, okay, forget about hot executive functioning for a moment because we can't get anything that sensitive because we're actually stressing them. So why don't we look at how stress appraisal and coping strategies affects kids and has a cascading effect on social emotional functioning. So take-home message is that CI users compared to normal hearing peers are at higher risk for social emotional deficits that may be related to how they appraise and cope with stressors. Clinical take-home messages. We think you should measure and track stressors. So we have a questionnaire called the SEEK that is available to clinicians where you can track parent-reported stressors. We also think that if you can model, label, and practice using emotional state language, that might help kiddos with stress and coping. So talk about your feelings. Make the abstract concrete. Use these feeling plus cause sandwiches. So instead of saying, David, give me back that toy, the new way would be like, I'm upset because your brother took away that toy, feeling, cause, and I'm going to tell him to give it back to you. Help the child label and describe their feelings. You look like you're mad because you're frowning. So making the abstract concrete. Last take-home message, label, model, and practice coping. So you could say, it is really frustrating when you can't get something to work, feeling, cause. What can we do next? So I wonder what if. And some acknowledgments, and thank you to all my colleagues who have let me run over my time. That's all.
Hello, my name is Cameron Cardin. I'm from the University of Alabama, and today I'm going to be talking with you about special education practitioner perceptions and practices when they're determining special eligibility for our preschoolers using listening and spoken language. I have no financial disclosures. So I don't know about you, but when I started out in this field and I was transitioning a child from early intervention under Part C services to Part B services in the schools, I really didn't have difficulty helping their caregivers through the process of getting them determined eligible for special education under Part B. But now, today, I feel like often I and the caregiver and the audiologist, we are hustling for eligibility and continued services, and we just can't seem to get them. And we just kind of have this shared experience of struggling for continued eligibility at the Part C to Part B transition. I want to talk to you today, though, about how our technological and early intervention advancements that we've made in the field have not ameliorated the need for continued services, but rather they've changed the way that we as practitioners need to identify those needs. So, the reduction in eligibility that we're seeing then is the result of a widening research to practice gap rather than a lack of need for continued services for our preschoolers. So the literature really informed the research questions and methodology that I used in this study, both related to evidence-based practice guidance and policy and practice guidance from IDEA and the National Association of State Directors of Special Education. And what the literature really shows generally is that in school-based contexts, practitioners demonstrate an over-reliance on norm-referenced assessment and an under-reliance on more ecologically valid assessment practices like language sample analysis, which is a functional language measure that's particularly helpful with preschoolers. But then specific to our children using listening and spoken language, the research also demonstrates that many of our preschoolers are scoring within 1.5 standard deviations of the mean on norm-referenced assessments, but they're continuing to show delays and disruptions in those functional language measures like language sample analysis. So that presents kind of a challenge space for our preschoolers and our families. Further, from a policy perspective, there are some shared criteria for determining eligibility under deaf or hard of hearing, such as the need for an audiological evaluation and documentation of adverse effect. However, no state requires a cut standard score, like a cut score model, for children who are deaf and hard of hearing, in the same way that a developmental delay determination obliges that model across most states. So the purpose of this study was to examine the experience, perception, and practices of school-based practitioners when evaluating our preschoolers using listening and spoken language to make those initial eligibility determinations. And then to define those potential policy and research to practice gaps and clarify the cause of those potential gaps so that we could then address how to best advocate and educate practitioners to continue to provide services to optimize outcomes, particularly for our children with cochlear implants or single-sided deafness. what we would often consider today to be some of our higher performers. So I wanted to know how special education practitioners' assessment practices aligned with current recommendations for evaluating preschoolers using LSL, and what the relationship was between certification and understanding of eligibility criteria for deaf or hard of hearing. You may have a different term for that eligibility criteria in your state, but I'm going to use deaf or hard of hearing today. So this was a survey study that included 149 participants that were either teachers of the deaf, speech-language pathologists, early childhood special education teachers, or special education teachers evaluating preschoolers for eligibility as part of their responsibilities in their school-based contexts. You can see that there was a pretty even spread across those three major certification or licensure groups, and they were a highly educated group with a lot of experience across 34 states. So the survey that they participated in had 4 sections. One to determine their evaluation practices for determining eligibility with preschoolers using LSL. Another to determine their perceptions of the eligibility requirements for determination under deaf or hard of hearing, a demographic section, and then the speech-language pathologists continued on for a 4th section about their assessment practices for preschoolers who are deaf or hard of hearing. I'm going to just share with you some descriptive statistics and an ANOVA analysis in this talk. So first, we know that the literature shows, and IDEA supports and NASD supports, a variety of expertise participating in an eligibility decision. You can see that on average, practitioners reported about 4.88 people on average participating in decisions for preschoolers using LSL. Obviously, speech pathologists are at the table the most often, about 96% of the time. So almost always there's a speech pathologist in this decision. After that, a special education teacher about 72.5% of the time, a teacher of the deaf, roughly the same, and then unfortunately you can see the educational audiologist is only present in this decision just over half of the time. When we talk about evaluating developmental areas, NASD recommends evaluation of the following 6 developmental areas for preschoolers using LSL: audition, vision, spoken language, speech, cognition, and social emotional development. So of the practitioners who completed this survey, it was a Likert scale of how often these developmental domains were assessed. There was an option for I'm not sure. You can see that special education teachers, almost 40% of the time, were unsure whether audition is assessed for our preschoolers. Okay, and social, emotional, and vision also about the same. I'm not sure about the vision because all children have to have a vision screening. But you can see then that speech pathologists were just under that, with a fair percentage of the speech paths reporting they weren't sure whether these domains are assessed. And then, of course, teachers of the deaf least often reporting whether or not they're unsure that those domains are assessed. So those are the practitioners without knowledge, okay? Then when we look at the practitioners who reported knowing how often these developmental domains are assessed, audition, vision, spoken language, speech, and cognition were reported to be assessed most of the time. But social emotional development, which we know is critical, was reported to be assessed about half the time to most of the time. And the majority of practitioners who reported assessing this were the teachers of the deaf. Well, if they're only there 2/3 of the time, then chances are high that that's not being assessed for our children. Typically, on average, the respondents reported that they were using about 5.67 measures when assessing preschoolers using LSL, most commonly observation, parent report, and norm referenced assessment. Least commonly criterion referenced measures, which, as we know as speech pathologists and listening and spoken language, are really, really critical in our work. When we just look at speech pathologists, of which I am one, 89.5% of SLPs reported using norm referenced assessments during that transition period from 30 to 35 months, and about the same for those traditional preschool years. I specifically asked about the PLS And you can see that 61% of speech pathologists reported using that measure during the transition and about half during the 3 to 5-year-old years. I asked about that measure, not because I don't think it's a valuable measure, but Pearson describes the purpose of the PLS as a functional language measure, which does not align with the purposes of an eligibility determination for determining whether the child has equitable access to age-appropriate activities in the classroom. The SELF is designed for that purpose, but of course we can't use that under 3. Then when we look at more ecologically valid measures like language sample analysis, which does show sensitivity for our children, 45.3% of the speech pathologists reported using that measure about half the time or less. When we look at understanding eligibility criteria under DHH, I compared the 3 disciplines and their understanding. There was a significant difference with a medium effect size for just a general understanding of those criteria, with the speech pathologist demonstrating better understanding of the criteria. But what's interesting is that the thing that was most challenging to understand for practitioners was the cut score. So I specifically asked, is a cut score required for determination under deaf or hard of hearing? And many of the respondents said that there are, which is a lack of understanding of the policy and their administrative code in their state. There was also a significant difference between groups here, with teachers of the deaf more often understanding a cut score is not required, then speech pathologists, and then special education teachers. This is not surprising because in school-based context, many of their determinations are made under developmental delay, which does use a cut score model. So I think we just have a phenomenon potentially of overlaying our common framework with an uncommon population in a school-based context. So when we look at an analysis of these findings, we see that norm-referenced assessment use is consistent with previous findings. There continues, even for our children, to be an over-reliance on norm-referenced performance when assessing a child for special education eligibility. And there continues to be an under-reliance on more ecologically valid functional language measures like language sample analysis. Additionally, when we look at how our practices are aligned with recommendations, we seem to be meeting the benchmarks for quantity but not quality. So there are the right number of people around the table, but they might not necessarily be the right people. And we're using a variety of measures, but we might not necessarily be using the right measures. And then, of course, we appear to have a real challenge about a policy to practice gap with understanding in more general disciplines like speech pathology and special education that a cut score is not required for our children who are deaf or hard of hearing. And how many of us have been in an eligibility meeting where we were told, or the family we were serving was told, well, your child doesn't qualify because their PLS score is too high? Like probably all of us. So the implications for this work, from a policy to practice perspective, we really need to emphasize pre-professional preparation programs and educating on the variety of eligibility criteria across those 13 categories, and specifically for us, that a cut score is not required. Documentation of adverse effect is required, and that can take many different forms. It does not oblige a cut score. Some additional findings in my research indicate that practitioners who believed that there was a cut score were more confident in their eligibility determination practices than participants who didn't. So I think kind of emphasizing the training and pre-professional programs is probably going to be more effective. If you think you understand how to if you think you understand how to determine eligibility for a child who's deaf or hard of hearing, you're not going to go to a continuing education opportunity offered about it, right? So we really need to emphasize those training opportunities in our pre-professional preparation programs. We also need to ensure that teachers of the deaf and educational audiologists have a place at the table. They're the only people in a school-based context, unless the parent brings someone else, that have specialized knowledge of working with our children. And for some of those developmental areas, the only person with whom that area falls within their scope of practice are the TOD and the educational audiologist. And then we need to have a particularly concerted focus on professional development for SLPs, learning how to leverage more evidence-based assessment practices for children who are deaf and hard of hearing, and then more general training across disciplines for practices for evaluating all of the developmental areas. Just because a child has a high PLS score does not mean that they don't exhibit some social emotional challenges that are going to prevent equitable access to age-appropriate activities in the preschool setting. So I know that this is like 0.4 font. I am so sorry. But I do just want to share with you that Betsy Brooks, Christina Blazer, and I have an evaluation checklist in press right now specifically related to an evidence-based framework for evaluating preschoolers at that Part C to B transition. Okay, so here we have taken all of the developmental areas that NASD has recommended be evaluated, and we have provided evaluation tools for each one of those areas. We understand that some of these measures are unique to children who are deaf and hard of hearing, and it's a low incidence population. So almost all of those assessment tools are open access that could be accessed in a school-based context. Then over on the second part, we have an evidence-based evaluation framework for language related to vocabulary, receptive and expressive language, and then evidence-based language assessment practices related to context, collection, and analysis. In the manuscript that goes with this, we have aligned each one of these recommendations with the evidence-based practice literature to try to do that heavy lifting, because we know that when you go in and you ask for these practices, but you don't have the evidence-based support, sometimes they're ignored. We also have in the manuscript the language that we've used in the school's vocabulary to help these children, help justify adverse effect in the way that the school system needs to hear that in their vocabulary. So I hope that you will find that helpful when it comes out in a couple of months. Thank you.
All right. Okay. Good afternoon, everyone. My name is Evan Patel. I'm one of the PGY4s at the University of California, San Francisco. And I'm going to be talking about how access challenges and family support are associated with language development for children with hearing loss. I have no disclosures. So 1 in 500 children are born deaf or hard of hearing, which puts them at risk for delays in language development. We try to mitigate these delays with early identification and intervention, which includes things like hearing aids and cochlear implants. However, the cornerstone of management for these kids is speech and language therapy with someone with significant experience in oral rehabilitation. There are a number of different demographic and clinical factors that affect language performance in this population. And some factors that have previously been associated with language outcomes are listed here, which include income, insurance, race, ethnicity, education, and access challenges, with some of the clinical factors being hearing level at diagnosis, age of identification, comorbidities, and the etiology of hearing loss. Our goal in this study was to identify different social factors which impact language outcomes that are precise and intervenable. In particular, to identify root modifiable causes which impact language performance in order to optimize outcomes and address disparities. In particular, we wanted to assess how access challenges affect language in deaf and hard of hearing children. So we performed a secondary analysis of a prospective randomized clinical trial of a large cohort of a diverse group of deaf and hard of hearing children. This occurred at 4 tertiary care hospitals across the United States and included baseline data in a trial that was used to test the effectiveness of teletherapy on language disparities in deaf and hard of hearing children from low-income backgrounds. The trial was specifically designed to include a diverse population and gave us an unprecedented opportunity to look at demographic factors related to access challenges. It was designed so that 2/3 of the patients included in the study would be from a low-income background. Regarding income, we chose 266% of the federal poverty level as the cutoff for the low-income group, which is the cutoff for California Children's Services. We had 172 children in our study aged 0 to 27 months with any permanent hearing loss. 61% came from a low-income background. 75% were persons of color. And then in terms of language spoken at home, 62% were English-speaking and 38% were Spanish-speaking. Those were the two languages that our language testing was available and validated in. Data was collected in a prospective manner to minimize bias, and assessments were also combined with routine clinical care to minimize dropout. As we know, the patient population has specific needs that benefit from a specialized provider with experience in oral rehabilitation, and the factors underlying language disparities in deaf and hard of hearing children have been proposed to be related to access to care. So we decided to look at the Access Challenge Index, or ACI, which is made up of 3 different subscales: family structure and support, which has the components of things like housing, job status, social supports, and access to transportation. And then the other 2 subscales are the educational environment and educational support services. Each of the components are scaled from 0, meaning no concern, to 5, meaning highest concern. And the ACI is calculated by someone on the team that typically knows the family the best, which could be a social worker, audiologist, or speech therapist. In terms of language outcomes, we use the preschool language scale, as we were just talking about, or PLS-5. This is a standard developmental language score valid up until age 7. And then we also looked at the Receptive Expressive Emergent Language Scale, or REAL, which is valid up until age 3. So the PLS has kind of a wider age of applicability, but the REAL is a more comprehensive test. All right, so the first thing that we did is we looked at a simple linear model comparing PLS total language and ACI. And as you can see here, the language score is here on the y-axis, with age-appropriate language being at 100 with a standard deviation of 15. And then ACI is here on the x-axis, use a laser pointer, with higher numbers associated with greater access challenges. And we found that greater access challenges were associated with worse language outcomes. And in particular, significant ACI, or access challenges, were 2 standard deviations below those with no access challenges. To put this in perspective, the 2017 Australian study looking at language outcomes after cochlear implantation found that language outcomes in patients implanted closer to 36 months of age were about 2 standard deviations below those implanted between 6 and 12 months. So as we can all see, this is a pretty significant difference. When we looked at our REAL data set, we found very similar findings. So the REAL has a receptive and expressive component, which are both out of 100, and then combined out of 200. So you can see here that it's a very similar correlation between greater access challenges and worse language scores. Then we performed a multivariable analysis in order to control for different covariates that might be affecting our relationship between access challenge and language index or language performance. In our PLS data set, we found that genetic etiology, hearing level in the better ear, and ACI were significantly associated with language outcomes when controlling for all these other variables listed here. When we looked at our REAL data set, we found that hearing level in the better ear as well as ACI were the only 2 variables, so very similar to the PLS data that were associated with language performance. Going back to our original diagram, while these other variables have been associated with language in the past, on multivariable analysis in our data set, just access challenges and hearing level and etiology of hearing loss were associated with language outcomes when controlling for these other covariables. I want to modify this graphic just a little bit because I think that we like to think of access as a little bit more of an intermediate factor between demographic factors and language outcomes. Access is something that's modifiable, unlike some demographic factors, and it's also something that can overcome certain social disparities by improving utilization of healthcare. Then we looked at each subscale and its relation to language outcomes. So educational support, educational environment, and family support. And we found that family support was the only subscale that was associated with language outcomes in the PLS and also our real data, which we found particularly compelling. As a reminder, the family support subscale of the ACI is made up of financial and social stability of a family, and includes things like access to transportation and other things. So a few conclusions. Access to specialized healthcare is associated with language outcomes in deaf and hard of hearing children. Moreover, this relationship of access to care and language outcomes is maintained when controlling for other clinical and socio-demographic covariables. This is particularly important to highlight as being a particular racial or ethnic identity is not the risk factor for these families in terms of language outcome, but rather the increased barriers in terms of to care that these marginalized communities face are the difference maker in language outcomes for deaf and hard of hearing children. And we understand that family factors were the largest predictor of access to care and should be targets for future intervention. We do appreciate that these experiences present incredibly heterogeneous data and that we need to investigate them further with additional studies. However, we're starting to understand how much of an impact access to care has on hearing and language outcomes, and framing the inequity in outcomes from a lens of access to care allows for future interventions to target families with higher ACI scores. And these interventions could include anything like a social worker or a community health worker to work with these families with higher ACI scores. And then future directions would be to design and test these interventions on hearing outcomes and put resources into implementing these interventions. I'd like to thank everyone else who helped me with this project. Nima, one of our medical students, our amazing audiology and speech and language therapy team, and Dr. Chan for his mentorship. Thank you.
Thank you, Evan. You set the bar and the microphone high, so we're just going to adjust that here. I'm Anna Maria Sola. I'm one of the residents, otolaryngology residents at UCSF, and I'm really excited to present my project today. The motivation of the project is essentially to look into caregiver-child language and see if that predicts post-cochlear implant outcomes. And I'm very lucky to have worked with my mentors, Meg Sikosh and Dr. Dylan Chan. I have no disclosures. Here's a brief roadmap of the presentation today, fairly standard format. I don't have to tell everyone in this room that children who have a diagnosis of hearing loss are at risk for speech and language delays that are permanent. And the cornerstone of our management really relies heavily on speech and language assessments, many of which happen in clinic. And these really help us dictate treatment for children who are deaf and hard of hearing. These do have some issues that come along with them. If anyone in this room has ever performed a PLS-5 on a screaming toddler, they may know what I'm talking about. It's occasionally hard to get our pediatric patients to cooperate or quote unquote perform in clinic. In addition, these assessments are time-consuming and certainly take up significant resources. And I think another critical piece is that there is a whole body of literature that suggests that in typically hearing children, home language environment is actually one of the most predictive measures of future outcomes. And so in response to this need, our clinic has been increasingly using a research tool called Lena. This is essentially a recording device that a child wears in these cute little vests pictured here. and the child wears it throughout the entire day. And for us, this has become a way of performing assessments at home that are clinical in nature. And while this has been historically used as a research tool, we are very interested in using this as a clinical tool. And in order to do that, we need to understand more about these measures, what they mean, and what the impact is for our patients that we're treating. So let's put this technology into perspective. Many of us have heard of the studies published by Hart and Risley. These were two researchers who were very interested in speech outcomes. They were performing research in Kansas during the war on poverty, and they were very interested in assessing speech and language in home settings. And they would physically enter the homes of participants, the research participants. They would be there for an hour every week, and they did this for a few years. And they had some important findings, although today, somewhat controversial, and we are rethinking some of these findings. But they did show that there was an adult word gap by the age of 3 in children who were of lower socioeconomic status. And while controversial, these findings were certainly impactful. And so this influenced federal funding, the creation of early start programs. What Lena provides for us is an opportunity to perform similar work in a much less intrusive way. And so we're able to enter the home of our patients and gain clinical information without actually being there. In other words, we've heard big data thrown around in medicine, and any of us who have an Apple Watch know that this can monitor your heart rate, your EKG, your sleep, and we are coming to our doctors with this information. And in the same way, we now have a tool where we can gather big data on our very little deaf and hard of hearing patients. And what I really want to emphasize is, this has been used as a research tool, but what we're going to focus on today is how we might be able to use it as a clinical tool and a rehabilitation tool. Okay, so let's dive into the research questions. We're all familiar with this framework. So children are exposed to sound and they develop speech and language. This is a little bit different for our children who have severe to profound hearing loss. There's a paucity of sound. They then gain sound after cochlear implantation, for example, and then develop speech and language. So we're going to focus on 2 research questions today. The first is truly a question that has been researched at length. We've gained lots of information on this over the decades, but we're going to ask some questions using this new system, and that is, after a child with severe to profound hearing loss gains access to sound, how do they develop speech and language? And then how does this compare to their typically hearing peers? And then question number 2 is really the novel question, which is, can we use these automated speech measures to predict the future language outcomes of our patients who are deaf and hard of hearing? So let's dive into the methods here. Again, you have a picture of the hardware device, which is the Lena device. These children would wear these devices throughout the day for 3 to 4 days. And then we are able to automatically get that information loaded onto a server that we can then analyze. Our study population includes 25 children, all with severe to profound sensorineural hearing loss. They all underwent bilateral cochlear implantation at an average of 13.8 months. Their ages range from 3 to 47 months during the time of recording. We had 3 included languages. And families would complete 1 pre-implantation recording, followed by a variable number of post-implantation recordings. In total, we had 4,200 hours of recordings from deaf and hard of hearing children. We had a sample of 329 typically hearing children with 38,000 hours of recording. The 2 metrics that we will focus on today are child vocalizations, which are fairly self-explanatory, and then conversational turns, which are meaningful interactions between a child and a caregiver. A few things to note about both of these measures, and that is that, while Hart and Risley were looking at adult words directed at a child, we're really interested in what children are doing with this input. And so these are both child-directed measures. The child needs to be participating in order for these measures to occur. And the second thing to note is that conversational turns using this system have been identified in the typically hearing population in prospective trials to be predictive of future language development. So let's keep that kind of in the back of our minds as we move forward. So we'll start with our first research question, and that is very simply, as a child gains access to sound after cochlear implantation, how do they develop speech and language? So to start off with, we have two graphs. On the left, we have child vocalizations on the y-axis, and then on the right, we have conversational turns. The green part of the graph demonstrates pre-implantation child vocalizations or conversational turns, and then the orange is the results on average over the first year after implantation. And I want to point out a few things. You can see quite simply that there is an increase in child vocalizations and conversational turns after cochlear implantation. But perhaps the more surprising finding, and I think of great interest, is if you focus on the pre-implantation bar, these kids with severe to profound hearing loss, with what we would consider limited access to sound, are vocalizing, and they are having meaningful conversational interactions with their caregivers. And this was quite surprising to us and something that you'll see moving forward through the presentation. So now we're going to look at the same data, but broken up into 6-month aliquots so that we can kind of get a sense of the timing of these changes. And what we see is that there's a steady increase in child vocalizations after cochlear implantation, even within that 1 to 6 month range. And as we heard Dr. Carl talk about earlier today, there is really a sudden neuroplasticity increase in neurons that occurs after access to sound is gained, and we see that here in these child vocalizations. Interestingly, when we look at a higher order outcome, so conversational turns, not just babbling, but having a meaningful interaction with the caregiver, also steadily increases over time, but we can see that there's a slight delay, and you don't see that impact right at that 1 to 6 month time point, and it's really at the 6 to 12 month time period that we're seeing that rapid increase in conversational turns, suggesting, again, that this is a higher order developmental outcome. So now let's compare our kids with cochlear implant to typically hearing children. And so on the left, you have a graph which shows total child vocalizations on the y-axis, and then the child's hearing age. So this is adjusted for their time to implantation, and what we see, again, is a rapid increase in child vocalizations, and that increase is actually fastest in those first few months. And then another really critical point is that they're actually outpacing their typically hearing peers in this analysis. When we look at chronological age, so just comparing baseline date of birth between cochlear implant users and typically hearing children, we see again a steady increase, but what we see is that there's a bit of a plateau, and then these kids that are implanted are catching up at later time periods. So in summary, for our first research question, we've corroborated what we know to be true, which is after cochlear implantation, children rapidly develop speech and language skills. So now let's focus on our second research question, which is looking at things backwards. Let's look at these automated speech metrics before cochlear implantation. Can any of them help us predict which kids are going to do the best on their future standardized language assessments? So same group of kids. Now what we're looking at here is on the y-axis, we have PLS-5 scores. As we've discussed, this is the preschool language scale, 5th edition. This tests both expressive and receptive language development. We took these results 19 months after cochlear implantation on average, and then we correlated them with preoperative child vocalizations and conversational turns. And you can see after a simple Pearson's correlation, there's a strong correlation between both child vocalizations before implantation and their future language development. We then performed a multivariable linear regression where we controlled for degree of hearing loss, gender, maternal education, and what we found was that only conversational turns out of all of these speech metrics were significantly associated with future language development. And the effect size was quite meaningful. So for every point increase in the standard score of conversational turns, there's a 5-point increase in the standard score of a PLS-5 assessment. So in conclusion, today we've talked about a new research tool that our clinic is interested in using to really perform clinical assessments in children who are undergoing cochlear implantation. It's really a way to harness big data for our patients. And what we've found today is that we can see expected changes in development after cochlear implantation. We can also find out some new things. We didn't expect to see such a meaningful amount of vocalization and child interactions with their caregiver before even cochlear implantation. And unlike previous studies that have focused on adult words directed at children, what we're really looking at in this study is child-directed speech and language. And so it's exciting to see that these findings corroborate what we know to be true. And novelly, we're also excited that this technology may have a role in helping us predict which patients will do best in regards to their speech and language development after cochlear implantation. As a surgeon, we love doing cochlear implants, but it's critically important for us to understand which of the children who we're implanting might be at higher risk for not having the outcomes that we're hoping for, and can we intervene early for these kids who are at higher risk? I'd like to say thank you to the whole team at the UCSF Children's Communications Center. They're pictured here. My email is listed here if anyone has any questions. And thank you so much also to all of my collaborators who are listed here. Thanks.
Thank you so much. Thank you, everyone. Please, there's microphones around the room. Step up and ask your questions of the speakers as you have them. We'd love to engage with you. But I thought I might get us started, and that is that I think it's pretty obvious that the importance of interaction, the importance of early, but I'm curious, we're really now moving into being concerned about higher order thinking, higher order skills. What, in your opinions or your experience, would you have the so what, like what would be the top 3 things that a clinician could inform a parent or be of top of mind could start doing to encourage higher order skills?
Thank you so much. Thanks so much for that question. We actually have one of our speech-language pathologists in the audience, Chiara Scarapelli, who actually uses these automated generated reports already to give feedback to families. And actually what she'll do is go through the trends of these various automated speech measures with a particular interest on conversational trends, but it even includes things like electronic noise exposure, which we've previously shown to have a negative impact on development. And so I think that just providing that kind of education and objective, direct feedback to the families has been critically helpful and a tool for people to kind of hang their hats on and say, I see that I'm increasing the number of interactions I'm having with my child, and here are the positive effects. And so that direct association that we see physically on the paper has been really helpful for the families that we're seeing in clinic.
Thank you. Yeah, it's kind of like we all like to compare or get in competition with our smart watches on walking and steps. It's the same kind of thing, increasing your turn taking. Yeah, good. Were you going to say something, Dr. Cronenberg?
No,
I see that. Okay, Andre.
Can someone turn on this microphone, please?
Yeah, now.
Oh, there we go. Thank you.
Yeah, thank you very much. I have a question to Dr. Sola regarding the communication before implantation. I was wondering, is that an acoustic communication or is it gestures that happen together with acoustics? And Lena reports that as conversational turns, but we have to be careful whether it's really acoustic communication or something else.
The report that you're seeing here is all acoustic communication, but our question is what are parents using along with acoustic communication? And so we were kind of perplexed at this data, and we reached out to folks, and one answer that we got was, there's a lot of tactile communication that happens in that young stage of infancy. Parents with their hands on their child's chest as they're speaking with them. Actually, children can feel the vibration of sound even if they have sensory neural hearing loss. And so one theory that we have is that this acoustic communication is potentially substantiated with tactile information as well. It's just a theory. I have no way to prove that with this machine, which truly only measures, audiometric data.
Yeah, thank you.
You had your mic on earlier, Dr. Cronenberger. Were you going to say something?
No,
answer the question about how.
Trying to figure out how it worked. I'm sorry.
Okay. Well, how would you answer the question of what the so what part is of what to encourage higher order and higher skill development?
Yeah, I mean, thinking about it from a information processing perspective, when you think about what a child or an adult has to do if they're engaging in language comprehension, I mean, the first thing they have to do is they have to store a certain amount of information at the same time. So, apologies, you always hear me talking about working memory, but I do think that's where it begins. They need to hold information in mind, and then beyond that, beyond just having the facts, they then have to be able to integrate them. And so there is an integrative process that occurs as well. As a matter of fact, a lot of clinicians here, I'm sure, and myself as well, work with kids who have phenomenal memories. They certainly get the trees, but then when we ask them about the forest, they've missed the forest. And I think certainly in therapies, making sure that we teach kids to see the forest as well as the trees is important. But then you also can communicate that to parents. Draw links, draw connections between things, talk about implications, talk about inferences, things like that. Dr. Castellanos and I did a paper years ago, an article years ago on concept formation, and found that memory was important there, but also that concept formation was, an at-risk domain.
Do you want to add anything to that based upon your work?
Other way. There you go.
Also trying to figure out the signs. To dovetail on what Dr. Cronenberger said about concept formation. So what is concept formation is for kids to be able to form categories of things. You can't hear me. There we go. What is concept formation? Concept formation is being able to form a category of things, and we find that that may be associated with kids' threshold for stress, because what helps with stress? Being able to use mental state language. What are emotions? Emotions are abstract, but if you can make them concrete, you can build concept formation and you can build stress resilience. So I think building language is the number one priority for these little kiddos, and definitely being able to model mental state language and appropriate stress and coping strategies is the key forward.
I think that kind of, in terms of as we think about auditory deprivation, and you think about the work, Cameron, that you've been doing in terms of looking at eligibility, what's been your experience of eligibility for audiological services, aggressive audiological management for children who've been pursuing listening and spoken language outcomes?
Well, I think that the thing that makes the difference so much in school-based context is a functional listening evaluation. Sometimes that's outside of social emotional development, like the one thing that really demonstrates an adverse effect. And so I think that we have to be really, really aggressive about advocating for functional listening evaluations in school-based contexts. And then the only person that can do that is the educational audiologist. From a kind of a so what perspective on higher order skills, though, when we evaluate the measure, the functional language measure that's showing these delays more sensitively, all of these studies are using the Hadley protocol, which elicits narratives. And so then I think from an intervention perspective, I would believe then that we need to be evaluating what's showing, like what's sensitively measuring these delays and directly targeting narrative capacity, because it is so predictive of academic and social success.
Yeah, the narrative abilities are true in terms of what that means for literacy. And I think we all want children, our final destination needs to be literacy and then higher order thinking and being able to do well in school and well in life. And so I think we have to think beyond just structural language.
We have another question in the audience.
Okay. Oh, sure. Thank you. I can't.
Sorry. Thanks, everyone, for the talk. Question for Dr. Castellanos. I had a question about whether or not you looked into electronic device exposure and usage as modulating hot EF in DHH versus non-DHH kids.
So not in this project, but you must be listening into our lab meetings because we are going to be doing that with older adults in senior living facilities to see how music intervention, individualized music intervention may play a protective role in executive functioning decline. And we also have a group of close colleagues who look at LENAs, so we're looking at how LENA recordings can predict language, but particularly functional language, which is what kids use for stress and coping. So you're right, that you're on the pulse of the research.
Amy? Go ahead.
Hello, and wonderful, wonderful presentations. This is a terrific afternoon. I've enjoyed all of them. I wanted to make a comment to Dr. Sola. I don't know if I think of conversational terms as a higher order linguistic skill, because normal hearing babies do this the day of birth. It is essential to the development of communication. And so to separate that somehow from the process of listening or babbling or vocalizing, I think might be almost skewing your results in some way, or perhaps masking them. I'm not sure, but I just offer that perspective.
I appreciate that. I agree. I think that it's potentially an overstatement. It's interesting because it's quite difficult in this data set to remove adult words or adult input from the analysis, but what would be really interesting would be to see, when you remove adult words, is this an independent factor, or is this all the same process? Mm-hmm. Which is what you're saying, and I think which is the most likely outcome, and that is that this is all a spectrum, and it's all the same process, and there's not a huge distinction between these different metrics. What we found is that at least maybe they're more valuable than some other metrics like adult words independently or child vocalizations independently, but certainly they're all part of the same spectrum of speech and language, and agreed that there are much higher order aspects of language that we learned about than just that simple interaction. Thank you.
Yes, thank you, thank you. And I wanted to ask Dr. Carden, your presentation has given me so much food for thought, because this is a problem we all face. It's like children are being punished for their success in schools. And I just wondered about the distinction you were making that a spontaneous language sample is somehow not a normative test, because we can certainly run analyses on spontaneous language samples with the DSS or with SALT to actually get normative data.
Yes, and so I think in my experience, I absolutely agree, and I think from a research perspective, we do that. That's how we analyze those data in that context. I think in the school-based context, we may have a feasibility issue with that type of model, and asking a speech pathologist with a caseload of 80 children, right, to kind of analyze at that level. And I think that there are some things that we can look at that might not require metrics or type that, like a specialized computer programming, even the sugar model, which I think is phenomenal, to kind of demonstrate adverse effect for the purposes of determining eligibility. So while clinically, absolutely, I do what you're saying and run all type of metrics on a sample, I want to make sure that I'm advocating something in a school-based context that's both sensitive and feasible for that school-based practitioner. And I think speech pathologists have the clinical skill set to look at a language sample and say, I can see an adverse effect here. I just want to make sure that they have the information to do that from an acoustics perspective.
Yes,
but
that
I
makes
absolutely
sense.
agree with you as
Thank
a best
you.
practice.
Thank you.
Thank you. I think, Mara?
Hi. Special thanks to everybody that presented, and I have a question for Dr. Carden. In our experience, so first, on behalf of everybody from Listen and Talk, we feel very validated by the information that you presented. I'm curious if there was any discussion about the role of the school psychologist in the triennial evaluation and their knowledge.
So absolutely, and if I had to do this study again, and I would like to include the school psychologist as well as the educational audiologist. At the time when this study was conceptualized, I perceived in my context that the individuals that were most involved in that high stakes decision making were the were the special education teacher and the speech pathologist. But as that model has evolved, I do think the educational psychologist is now more involved in that eligibility process in a way that I maybe didn't see them there as frequently in with preschoolers 5 years ago, let's say. But absolutely, I think that that because of the way, I guess, that I would say in my own experience, that they really are really in a kind of almost at that norm referenced paradigm, I do think that there's absolutely probably some work that we could do together to make sure that we're looking at more ecologically valid measures with that discipline as well. But I have also recognized the evolution and need to include that in a future sample, yes.
And while I'm at the mic, and the highlight of the concern about SLPs that are school-based who may not understand the eligibility criteria for children who are deaf, hard of hearing, I'll put in a plug for the teachers of the deaf in terms of analyzing that that language sample, and also the especially LISL-trained teachers of the deaf that can connect the link between listening and literacy as evidence of adverse educational impact.
I 100% agree, and comically, of the three groups that are represented in this study, I'm a speech pathologist and a special educator, and I came out advocating for the TODs, the only thing that I'm not in the sample. So I could not agree more with you that I understand that training programs are different for teachers of the deaf, and so maybe there's some methodology kind of perspectives, language perspectives that differ. But to get eligibility, no matter what your language modality you focus on as a TOD, you are probably the only person at the table who has specialized knowledge in how to make that determination for our children.
But I think there's great opportunities to educate professionals about that link between audition and academic and social success in that school setting. So thank you for raising everybody's awareness of this challenge.
So there are 3 more questions at the mic. We are at our time, but if you can ask quickly, those of you who need to take a break, get up, feel free to do so. If you are planning to come back for the adult portion, we look forward to seeing you then. But if you're going to leave, do so quietly so our panel can hear these 3 questions that we'll take quickly.
Thank you. Maura, thank you so much for mentioning that. I, teacher of the deaf, and now working in a professional program at Cal Lutheran University, preparing teachers of the deaf. In my experience, K through 12, very similar, but transition from Part C to Part B, teachers of the deaf, we come with this functional language assessment, and we are overridden by the PLS-5, which whenever anyone mentions it, it just makes me see red, because those usually show higher scores for our students, and therefore our students aren't offered SDC for preschool. They're being released, and they're getting no more support. And like the previous person asking the question said, they're being punished for doing well. And so my question to you, Dr. Carden, is with this publication that's coming up in 2 months, is there a plan to send that out or distribute it among school districts to make sure that we're all on the same page? Because it seems that every school district does something different. I've worked at LAUSD, at smaller school districts, and everyone seems to do it different. Nobody's the same, and I wish there was a way that everybody would follow the same rules to assure that our students continue to learn all these valuable skills that all these presenters have been talking about, but they can't if they're being released into gen ed and no longer receiving SLP services. They're on a 504, no SLP, no TOD, very important. What are the plans? And hopefully there are plans.
Yes, so it's in press right now, and the checklist is actually will be available through supplemental material so that it's more readily accessible. It has the embedded links, and from your with relationship to your comment about the PLS, on the second page, we've really done, and Christina Blazer contributed such beautiful work about isolating the items on the PLS and contextualizing those. But I think I'm not saying we don't, I understand we're never going to get away from standard scores, but there's also language in this paper to document that it was collected in a quiet environment with a single human, that was an adult, and all of these things. And so when we present these standard scores, we have to contextualize them, that they aren't reflective of the context that you're asking the child to be successful in. But in a language sample analysis, you can document all the ways that it was similar. And so I think that, I hope that the measure, there's also a case study that kind of explains how we talk about these to kind of leverage all of those facts. So I hope so. I hope everybody shares it. I cannot be doing this, fighting this fight when I'm 75 years old. I cannot. My mom fought this fight with my sister who is a cochlear implant user. My sister is fighting this fight with my nieces who are cochlear implant users. We cannot be doing the same thing in 30 years.
Well said. One of the things that I think is important, I keep looking and thinking about what we've heard this morning, and that is it's about auditory deprivation. And the reason why we're talking about all these things is because we aren't mitigating auditory deprivation, and our practices as a society don't reflect the urgency and the developmental emergency of how we should be treating hearing loss and mitigating auditory deprivation. So I don't know what our time is. Amy, you're our timekeeper.
I think that for the two people who are still waiting to ask a question, if you could find our presenters after this session and talk to them, I want to make sure that everybody who needs a break gets a break. And so please feel free to come up and chat with our presenters. I want to thank everyone on this panel. I want to thank Teresa for doing such a beautiful job moderating. I hope that all of you have learned something very valuable and have some take-homes that you can implement immediately as you go back into your organizations of practice. So thank you for being here, and have a great rest of the conference.